Hi everyone, in this video I'll be discussing antimicrobial drugs. So antimicrobial drugs, in this topic we'll be discussing what are the drugs used to treat bacterial infection, then the virus, fungus, protozoa as well as helminth. Now the branch dealing with antimicrobial therapy is also called as chemotherapy. What do you mean by chemotherapy? Chemotherapy is nothing but killing of cells. So antimicrobial introduction, I just want to introduce a word. The meaning of the word chemotherapy. So chemotherapy is killing of the cells. Now you can kill the microbial cell or you can kill the cancer cells. So if you kill the cancer cells, it is called cancer chemotherapy. If you kill the microbes, it is called as antimicrobial therapy. So we call the drugs as antimicrobial drugs. Yes. Now before I start this topic, I just want to ask you what are the microbes which are going to cause infection in humans, which are common? Let me write them. The common ones are what we have is the bacteria, then the virus. We all suffered with the virus, the pandemic, COVID-19. Then the opportunistic infection, fungal infections, then the protozoa, and then we have helminths. So we will be discussing the antimicrobial therapy depending on these headings: antibacterial drugs, antiviral drug, antifungal drug, antiprotozoal drug, and anti-helminthic drugs. So in this video, we'll be starting with antibacterial drugs and understand what are the concepts we need to understand in this topic, that is antibacterial drugs. Let us start our journey. The first important thing is we'll discuss antibacterial drugs. So let us start our journey, and that is antibacterial drugs. Now before I begin this topic, we need to understand there is a concept called antibiotics. Now what do you mean by antibiotics? Now there are certain chemicals produced by some organisms. These are chemicals produced by some organism and they kill other organism. Classical example you all know is penicillin. Now a fungus called Penicillium notatum, a fungus by the name Penicillium notatum produces penicillin, and that will kill the bacteria. So what is the criteria to call it as antibiotic? Number one, the substance should be produced by organism. Here the example is fungus. So fungus is producing penicillin and that is killing the bacteria. Then we call them as antibiotics, and they are used at lower concentration. So antibiotics is that many. Now what is the meaning of antimicrobials? So antimicrobials is a broad term which includes the antibiotics plus the drugs which are synthesized. They are synthetic drugs. They are not obtained from a fungus or a bacteria like that. They are synthesized. So antimicrobial drugs including antibiotics and synthetic drugs. So they kill the microbes. So remember one important thing: all antibiotics are antimicrobials. All the antibiotics are obviously antimicrobials. And remember, all antimicrobials are not antibiotics, because some of the antimicrobials may be synthetic drugs also, which are not obtained from another organism. That is the simplest understanding. So we understood the meaning of antibiotics. We understood the meaning of antimicrobials. So once we understand this, let us understand one more term. There is a term called bactericidal drugs. So in the future, I will be telling you these drugs are bactericidal. What do you understand by that? Bactericidal drugs are the one which kills the bacteria. So bactericidal drugs are the one which kill the bacteria. Now we have another term by the name bacteriostatic. So bacteriostatic drugs, what do they do? What do they do? They stop the multiplication of bacteria. Stop multiplication of bacteria. So that's the meaning of bacteriostatic drug. Stop the multiplication. You may ask a question, sir, hercidal, very good, you kill the bacteria, fine. But if you stop the multiplication of the bacteria, then who will kill those bacteria? We have the immunity that will come and kill. Suppose a person is immunocompromised or patient is immunosuppressed. If a patient is immunosuppressed, now you guess and tell me, should I give a bactericidal drug or a bacteriostatic drug in this patient? If a patient is immunocompromised or immunosuppressed, what will you give? Obviously, you will be giving a cidal drug. So, cidal drug, because if you use static drugs, the immunity has to come and kill the bacteria. So, these are the things we need to understand here. Now, once we understand this, let us understand the bacteria. Now, when I talk of bacteria, I want some of your microbiology understanding here. Bacteria are broadly the gram-positive bacteria, and we have the gram-negative bacteria. So, in that gram-positive, we have the cocci and bacilli. Here also in gram-negative, we have the cocci and bacilli. So, this is the two important classification of bacteria. We all know that. Apart from this, whenever we think of bacteria, you need to think of two major bacteria which are dealt separately and which multiply very slow. They are tuberculosis and leprosy. So, who will cause that? Mycobacterium tuberculi and Mycobacterium leprae. One more infection we need to deal is the anaerobic infections, anaerobes. Right? So, when we think of bacteria, you need to keep these things in your mind. Okay, so we understood positive, negative. These are the classification. We have cocci, bacilli, all these things. Now, once I know that, what are the infections what we see and what are the infection they are going to ask in the exam? Now, let us go from the head to toe. What are the bacterial infections we see of commonly? Bacterial infections, what we see and we need to treat. Let us go from head to toe. Number one, the meningitis. So, meningitis. Then the respiratory infections. The respiratory infections. So, these are the infections which we commonly see in our hospitals. The respiratory infection may be the upper respiratory tract infection or the lower respiratory tract infections. So, lower respiratory tract infection, we see the pneumonia. We have something called CAP. Sir, what is CAP? It is community acquired pneumonia. Then HAP, that is hospital acquired pneumonia. I am talking about bacteria. Then ventilator associated pneumonia. So these are the respiratory infection what we see. Then after that, what we see is the GAT infection. So the GAT infections are commonly seen. So in GAT infections, what is seen is the diarrhea and the dysentery. Diarrhea and dysentery and food poisoning. So food poisoning are seen in GAT infections. And also in GAT we see intra-abdominal infections. Intra-abdominal infection. So these are the infections in GAT. So before you learn the topic, you should know what are the common infections you see. So number one, meningitis, then respiratory tract infection, upper and lower respiratory tract infection, and then GAT infections. Then another important infection what is commonly asked is the UTI, urinary tract infection, very, very common. Then the sexually transmitted infections. Sexually transmitted infections. Sexually transmitted infection. So these are the major important conditions what they are going to ask you. Let me repeat that: meningitis, respiratory infections, GAT infections, UTI, sexual transmitted infection, and one more important infection by the bacteria is the skin and skin structure infections. Skin and skin structure infection. So skin infections and skin structure infection like carbuncle, furuncle, all these are skin and skin structure infection. Very common in diabetic patient. We see them in surgery very commonly. Now I'll give a general idea for you. Now when you think of skin infection and lung infection, it is more by gram positive. I'm not telling gram negative will not cause, more by gram positive. What are those? The skin infection as well as lung infection. The infections of GAT, that is diarrhea and dysentery, and urinary tract infection are more of gram negative. So let me repeat, gram negative, it is more of for causing the UTI as well as the diarrhea and dysentery. This general idea should be there in your mind. I'll be asking you in the future videos. So once you know the bacterial infections, you know why we should treat the patient. Because if I don't treat, patient will become sick. He may go for the complications also. So once we know the basics, we understood the various terms, antibiotics, antibacterial, cidal, static, and what are the bacteria and what are the bacterial infections commonly seen, right? We have discussed. Some of the bacterial infections like atypical infections are also seen with mycoplasma, chlamydia, rickettsia. We'll be discussing them later. Now, whatever the infection is, the question is, how do we kill the bacteria? How do I kill the bacteria? Let us know that. So let me draw the bacteria. So bacteria has a cell wall. So this is the bacterial cell wall. Okay, so inside the cell wall, we have a cell membrane. So I'm writing that cell membrane. So this is the cell membrane of the bacteria. So it has a cell wall, a cell membrane, and in the bacteria there is something called DNA, and the DNA will give rise to RNA. From RNA we get protein synthesis. So the protein synthesis occurs. Now there are certain metabolic pathways which will also important for contributing for DNA synthesis. So metabolic pathways are important for synthesizing DNA in a bacteria. Now what happens when the bacteria multiplies? When the bacteria multiplies, it requires a new cell wall, new cell membrane, new proteins, new DNA, and it requires the metabolic pathway for that. Now if I interfere with any of this step, then the new bacteria which is formed will not be able to survive. It will be killed. Suppose there is a building, you want to make one more building. You want the same brick, you want the cement, everything. Suppose if I stop the supply, you cannot make one more building. Same thing, if I interfere with the cell wall, cell membrane, protein or DNA or metabolic pathway, another bacteria, it's very difficult to multiply and get new bacteria. So what are the targets? The target number one is the cell wall. So the drugs can work on cell wall. The second target is the drugs can act on cell membrane. They can act on cell membrane. Number three, the drugs can inhibit the protein synthesis. Number four, the drugs may interfere with the DNA or DNA synthesis. Number five, the drugs can interfere with metabolic pathway. So if that pathway is interfered, the DNA synthesis will not occur. So we have five important targets: the cell wall, then we have the cell membrane, then protein synthesis inhibitors, the DNA synthesis inhibitors, and blockers of metabolic pathway. So we'll go one by one. We will start our journey one by one, and we have made separate video for that mechanism. So right now we'll be dealing with drugs affecting cell wall. So let us start our journey. So the first one is cell wall synthesis inhibitors. So these are called as cell wall synthesis inhibitors. Okay. Now what happens here is, this is the bacteria. Now if the bacteria has to multiply, it has to produce two daughter bacteria. Now if I interfere with the cell wall synthesis, the cell wall is not formed. So when it multiplies, the daughter bacilli will have, the daughter bacteria will have the defective cell wall. Now why the nature has given cell wall? To protect from external environment. Now why we have in the home walls? So that the rain, the wind will not come inside, we are not disturbed. But if that cell wall is defective, what happens? From the external environment, the water will gush inside. So when the water gush inside, the cells will swell up and they will rupture. So they will rupture like this. So that will lead to the bactericidal effect of these drugs. So they can kill the bacteria. So these are bactericidal drugs. So they will kill it. Now the point here is, you can work only, these antimicrobial drugs can work only when it is multiplying. So they can interfere with the cell wall synthesis. Sir, what about our immunity? Now our immunity can also do the job, but when the multiplication is faster, the immunity cannot cope up with that. So that's the reason we give antibiotics. They will help the immunity. Right? So that's the reason why we give the drugs. Now let us understand what are the drugs inhibiting cell wall synthesis. Let us start our journey. What are the drugs inhibiting cell wall synthesis? So we have the beta lactams. So first we have the beta lactams. The next what we have is a drug called bacitracin. The drug name is bacitracin. Then we have cycloserine. The name is cycloserine. Then we have phosphomycin. The name is phosphomycin. And then we have the glycopeptides. So the drugs which affect the cell wall are beta lactams, bacitracin, then we have cycloserine, phosphomycin, and glycopeptides. So I will give a simple mnemonic. The mnemonic is BBC. You have a news channel called BBC. They recently found ghosts. So the mnemonic is BBC found ghost. Now this glycopeptide drug, one famous drug, its name is vancomycin. The name is vancomycin. So moving on to what step in cell wall synthesis do they inhibit? Beta lactams, they inhibit a step called transpeptidase. So they inhibit the enzyme called transpeptidase. Now bacitracin inhibit bactoprenol dephosphorylation. So the dephosphorylation of bactoprenol is inhibited by bacitracin. Remember, it starts with B, bactoprenol. Cycloserine inhibits alanine racemase. Alanine racemase, and also it inhibits D-ala ligase. So D-ala ligase. Now phosphomycin, it inhibits enol pyruvate transferase. Enol pyruvate transferase. Now the glycopeptides, vancomycin, they inhibit an enzyme called transglycosylase. Now please mark two important things they will ask in the exam is this one. What step do they inhibit beta lactams? It's transpeptidase. What step the glycopeptides inhibit is transglycosylase step. So please mark these two things, the transpeptidase as well as the transglycosylase, very important. Now, in all these drugs, remember all the drugs are cidal in nature, but one exception is cycloserine, and that is the static drug here. So, cycloserine is a static drug. Almost all the BBC found vampires or ghosts, they are cidal, but cycloserine is a static drug. Okay, so once we understood the mechanism of action of these drugs, the cell wall synthesis inhibitors, let us start one by one. Now, before I introduce penicillin, I just want to tell you some specialty of these drugs. The drug bacitracin is used topical. It is used topically. So, topically for what? Skin infections. It is used in topically for treating skin infections. And second important, it is also used in carriers of MRSA. It is used in MRSA carriers. The drug is used topically. The name is called bacitracin. The next important drug is cycloserine. Cycloserine is used in tuberculosis, the TB, tuberculosis, but the adverse effect of the drug, we call this as psychserine. The reason is it causes psychosis in the patient and it also causes seizures in the patient. So it is also called as psychserine, but it is a static drug. I told you it's a tuberculostatic drug. The name is called cycloserine. Now another important drug by the name fosfomycin. Fosfomycin, it is used to treat UTI, used in uncomplicated UTI, uncomplicated urinary tract infection. One of the adverse effects of the drug is diarrhea. So the problem is diarrhea. So these are the three important drugs I have to tell you. Bacitracin, it's a topical one. We don't use systemically. Cycloserine for mainly tuberculosis. Fosfomycin for uncomplicated UTI. So these are also cell wall synthesis inhibitor. But mainly what we are going to discuss now is the first antibiotic to be discovered, and that name is penicillin. Now before I begin penicillin, you need to understand the first one, the meaning of beta lactams. Beta lactams. Now what do you mean by beta lactams? The beta lactams, they have a ring called beta lactam ring. So they have, this ring is called the beta lactam ring. So all of them have this beta lactam ring, and this is called the thiazolidin ring. It is called the thiazolidin ring. So since all of them have this beta lactam ring, they are called beta lactams, and the adjacent ring is called thiazolidin ring. Now what are the beta lactam drugs we have? The beta lactam drugs what we have is penicillins. Then what we have is cephalosporins. And we have another class of drugs, they are called carbapenems. And one more is by the name monobactams. They are called as monobactams. Now the reason why it is called monobactam because it has only the beta lactam ring. It doesn't have that thiazolidin ring. Now because of this ring, they are known to produce the allergic manifestation. So all these drugs can produce allergy. That means if a person is allergic to penicillin, there is a chance he is also allergic to cephalosporin. He also is allergic to carbapenems. And can you guess which drug doesn't have cross allergy? So that is monobactam. They don't have no cross allergy because they don't have that additional ring. So Suppose in the exam, if they ask you, patient has penicillin allergy and you need to give a beta-lactam, what will you prefer? Obviously, we'll prefer monobactams because they have no cross allergy. That's how the questions are framed. So we understood there are 4 beta-lactams: penicillin, cephalosporin, carbapenems, and monobactams. So let us start our journey. So before I start my journey, let us start the beta-lactams mechanism of action. How do they work? Beta-lactams mechanism of action. How do they work? So you all know the simple mechanism. They inhibit cell wall synthesis. Correct? That is a major mechanism. Correct? Now they also inhibit an enzyme called transpeptidase. So we all know that. And these drugs are bactericidal drugs. All these drugs are bactericidal drugs. Okay, sir, fine. Now, what is the in-depth mechanism of action? What do they do? In-depth mechanism of action, there is something called penicillin binding protein. So there is something called penicillin binding protein. Now, this is the place where the beta-lactams come and sit. So this is the penicillin binding protein, and it is mainly present in the cytoplasmic membrane of the bacteria. So there the drug will come and bind. So the drug beta-lactams will come and sit here. Now what happens when they sit here? Now once they sit here, the inhibit enzyme transpeptidase. The inhibit enzyme transpeptidase. Okay, sir. What is the problem? The problem I will explain to you. Now in the bacterial cell wall, we have a peptoglycan layer. So it is made up of 2 things. One is called N-acetyl muramic acid. One is called N-acetyl muramic acid, and one more is called N-acetyl glucosamine. N-acetyl glucosamine. So in the future, I will call this as NAM, and this one I will call it as NAG. So I call it as N-acetyl muramic acid and N-acetyl glucosamine. Okay, so we know what is NAM and what is NAG. So once I know this, what happens actually when the peptoglycan, that is cell wall, is forming? So the NAG will attach with the NAM. So this is the NAM. Again, you get alternatively the NAG. Again, we get the NAM like this. So this is one chain. Now again, we have another chain. This is again the NAM, that is N-acetyl muramic acid. Then we have the NAG. Then we have the NAM here. Again we have the NAG here. So like this, the chain keeps on continuously growing. Now what happens? There are some amino acids, they have to form a bond. So there are certain amino acids, they have to form a bond. For example, they will form a bond with NAM, will form bond with another NAM like this. Now again there is one more, the NAM will form the bond with one more NAM. So this is called the transpeptidation. So they are forming a peptide bonding so that the cell wall becomes sturdy, that is stronger. Now imagine when you are building a home, we put the bricks. Do you think we will only put the bricks? Now the bricks are nothing but this NAG and NAM, all these things are bricks. But when you put the bricks, we put the cement also, and that cement is this peptides. Now if that is not there, what happens? The cell wall is not strong, it is weak. Like if you build a wall without any cement but only with the bricks, if you hit once, it will break down. So this cross linking is done by the enzyme transpeptidase. So the enzyme which is responsible for the cross linking and making the cell wall stronger is transpeptidase. So if I use the drugs beta-lactams, they inhibit this enzyme. What happens? Then cross-linking will not happen. The cell wall becomes weak and the cell will die. So this is the mechanism in detail. So let me repeat again. The drugs bind to penicillin binding protein, which is present in the cytoplasmic membrane. And after binding here, this is the target. They inhibit the enzyme transpeptidase. Now, what happens in cell wall? There are two important molecules, NAM, that is N-acetylmuramic acid, and N-acetylglucosamine, and they are sitting one layer above the other. So they have to be cross-linked, and that is done by transpeptidase. If you inhibit that, no cross-linking, the cell wall becomes weak and the cell will die. So that is the mechanism of action. Okay, so we understood the beta-lactam's mechanism of action. Every beta-lactam has the same mechanism of action. In beta-lactam, the first one what we are going to discuss is the wonder drug of the century. They are called penicillins. So the penicillin is the penicillin G. It is the penicillin G. Now, who discovered that? The scientist name is Alexander Fleming. So his name is Alexander Fleming. Now it's an accidental discovery. Fleming went out in a vacation. When he came back, there was growth of fungus. Wherever the fungus was growing, the bacteria was not multiplying. There was no bacterial growth. So then he discovered there is some substances produced by the fungus which is inhibiting the bacteria. So then he discovered penicillin, and later it was commercially produced in larger quantity in 1940. So which was a wonder drug during World War. So penicillin G was discovered by Alexander Fleming. What is the source of this? Source of this drug is penicillium, notatum. So that was the initial source. Nowadays we are synthesizing commercially. For commercial preparation, we use something called Penicillium chrysogenum. But initially we obtained that from the source called Penicillium notatum, which is a fungus. So that is a brief history. Why should we know the history? So that future we also contribute for the welfare of the human beings. But you may think that Sir Alexander Fleming was accidental discovery, but even though it is accidentally, he had a very good observation capacity. And that is what we require as a doctor. Very good observation. Yeah. Now, once the penicillin G was available, penicillin G is also called by other name. It is also called as the benzyl penicillin. It is also called as the crystalline penicillin. It is also called as the aqueous penicillin. So all are same. So we have the penicillin G, benzyl, crystalline, aqueous penicillin, they are same. Now, what was the shortcoming of this penicillin G? What was the drawback of penicillin G? Penicillin G was very short acting. It was short acting and it was working for 1 or 2 hours, that's it. Very short acting, and you can give it either IV or you have to give it intramuscular. So it is given either IV or intramuscular. Second important thing is you cannot give this orally because it was acid labile. Acid labile means when you take it orally, the acid used to deactivate the drug. The drug is not going to work. Then another problem what we faced was it has having narrow spectrum. Now, what do you mean by that spectrum of activity? Spectrum of activity means what do they cover? Now, they were covering mainly the gram positive more than gram negative. Their coverage was mainly for gram positive more than gram negative. Now, another important thing is they used to cover the spirochetes. Spirochetes, that is the one which causes syphilis, that is Treponema pallidum. Then they used to cover the Neisseria meningococci. They used to cover Neisseria gonorrhea also, but now they have acquired resistance for that. Then in anaerobes, they used to cover the Clostridium. But the problem is they never covered no effect on no effect on the major bacteria. The group is called Enterobacteriaceae. They are called as Enterobacteriaceae. So these are the one which are known as E. coli, Klebsiella, Salmonella, Shigella, Proteus, and they are responsible for the UTA and GAT infections. So those were not covered, and that's why it was called a narrow spectrum one. That is the problem. So they used to cover gram-positive, spirochetes, Neisseria, meningococci, Clostridium species, but they couldn't cover Enterobacteriaceae. Now the spectrum of activity was the third problem. What is the fourth problem? As we started using them, patients, the drug started acquiring resistance. So we had to overcome these problems. So number one, it was shorter acting. Number two, it was acid labile. Number three, narrow spectrum and resistant issue. So let us overcome this problem one by one. Let us overcome this problem. So we came with a penicillin, which was very long acting. Now, what are those penicillins? How to make the penicillin long acting? So increasing the duration of action. How do we do that? Duration of action. There are two ways. Number one, penicillins are excreted in kidney. Let me write a nephron here. Yes. So this is the nephron, and the penicillin is thrown out. Penicillin is secreted with the help of organic anion transport protein. So this will secrete penicillin out. If it is going out, obviously the drug will be shorter acting. Then what they did is they used something called probenecid. Now probenecid will inhibit this OATP transporter. So what happens if you inhibit this? The penicillin stays inside the body and it becomes longer acting. So this was one method, but nowadays not used. So one of the drug interaction they can ask in the exam, what is the interaction between probenecid and penicillin? Obviously, the probenecid will not allow penicillin to get secreted and penicillin becomes longer acting. Right. What they did is, now when we give the drug IV, what happens? It will get distributed, metabolized, and it will go out faster. Because IV has no absorption, no first pass metabolism. But when we give it IM, the drug is absorbed very slowly. Now, how to make a drug absorb very slowly? Attach a group for that. If I attach the group for that, slowly the group is released, penicillin is absorbed slowly. So they started attaching the group. So the number one, we have a penicillin called procaine penicillin. Procaine penicillin. So they added procaine penicillin. Should I give this IV? No. If I give IV, it will be short acting. So they should be given intramuscular IM. And the duration of action is around 12 to 24 hours. So it can be given either once daily or twice daily. Procaine penicillin. But the problem with adding procaine is the patients experience seizures because of the procaine component of penicillin. Second important one is by the name benzathine penicillin. So don't confuse benzyl with benzathine. Benzathine penicillin. Again, this drug is given intramuscular. And how many days does it work? Very, very interesting point. It works for 21 to 28 days, not hours, days. So when we give it into the gluteus, slowly it is released and it achieves the blood concentration. You may ask a question, sir, which condition do we use the drug for 28 days once or 21 days once? There are two important conditions where we use it. Number one, it is used in rheumatic heart disease prophylaxis. Rheumatic heart disease prophylaxis, we use it every 21 days, one injection IM. And it's a very, no, it's not a costly drug. It's a very affordable drug. You can get it within 50 rupees. Okay, it's an affordable drug, don't worry. Second important thing, it is also a drug of choice for all stages of syphilis. All stages of syphilis, the drug of choice is benzathine penicillin. Except neurosyphilis. Except neurosyphilis, So neurosyphilis, the drug has to enter the brain, and the benzathine is big in size. It cannot cross the blood-brain barrier, so we cannot give it. We have to give a smaller drug, and the drug of choice for that is the aqueous benzyl penicillin or the aqueous penicillin. Mark this. This was asked in your recent exam. Again, they will ask you what is the drug of choice for syphilis. Still today, the best drug for syphilis is penicillins. Best drugs. So we know we came out and we solved the first issue. Increase the duration of action. So make penicillin propiocin. So we solve this issue. We increase the duration of action. So we combine propenicillin with penicillin, but not used nowadays. But what we are using is combining with a group, procaine and benzathine. So these penicillins are also called as repository penicillins. Repository penicillins. Okay. So these are longer acting. Okay, we got the solution for that. Increase the duration of action. Then what are the next problem? So tell me. So they were acid labile. So we need to find out the drugs which are acid stable penicillin. So we have acid stable penicillins. That means you can give them orally. So can I call them also as oral penicillins? Obviously, we can call it like that. Now what are these? Now it's simple to remember. You write a drug by the name oxacillin. You should know this name, oxacillin. For that you add Cl. Now you read, it becomes cloxacillin. For that you add a di. Now the name becomes dicloxacillin. So all these drugs are oral drugs. Then we have the drug by the name amoxicillin and ampicillin, which you already know them. Amoxicillin and ampicillin. Then we have a penicillin called penicillin V. So these are the oral penicillins. Now if you don't want to remember like this, we have a mnemonic OC. Vada. So what is O for? Oxacillin. What is C for? Cloxacillin. V for penicillin V. A for ampicillin. D for dicloxacillin. A for amoxicillin. So you can have the mnemonic. If you don't want a mnemonic, it's simple. If you know oxacillin, the other drugs can be derived. Amox, ampi, you already know. So penicillin G we discussed, but this is penicillin V. So we came with the good news. We got the orally active drugs. Okay, fine, sir. Now, what was the third problem we had? They were narrow spectrum. Now, what do you mean by spectrum of activity of an antimicrobial? The spectrum will tell us what bacteria do they cover. Do they kill only gram positive? Will they cover only gram negative? So, accordingly, the spectrum of activity, we can write it like this. The narrow spectrum, that means they cover only gram positive, some gram negative. Then extended spectrum, so they cover more bacteria, and the broad spectrum antimicrobials. So this is the meaning. Narrow means lesser, extended means medium, broad means more. So this is the spectrum. Now I told you the penicillin G was having narrow spectrum, so we came with one more, and these are called the extended spectrum penicillins. These are called as extended spectrum penicillins. Yes, so we got them. The advantage of extended spectrum penicillins are they were covering earlier gram positive. Now they are also covering the gram negative. In gram negative, they started covering the Enterobacteriaceae. So they started covering them, E. coli, all those things. So they have extended spectrum. In extended spectrum, we have a group called the aminopenicillins. So first we will discuss the aminopenicillins. So how did we get this aminopenicillin? By adding some different groups to the penicillin. Now what is penicillin? It's a chemical. For that, if you alter the targets, that means if you alter the drug structure, you get Aminopenicillin. In aminopenicillins, these can cover the gram positive, the gram negative organisms. Now here we have two important ones. One is by the name amoxicillin and one more is called ampicillin. So we have amoxicillin as well as ampicillin. Is there any difference between the two? Is there any difference? Let us understand that. Yes. Difference number one, amoxicillin is longer acting. Comparatively, it is given 3 times a day. But ampicillin is shorter acting. You have to give 4 times a day. 4 times a day. Then another advantage of amoxicillin is it is completely absorbed. When you give the drug, it is completely absorbed. Completely absorbed. So what is the advantage if the drug is completely absorbed? The advantage is there is no chance of super infection. Sir, what is super infection? What happens if the antibiotics or antimicrobials are not absorbed? They will go and kill our normal flora. When you kill our normal bacteria, which are good for us, the pathological bacteria will multiply and they cause infection of GAT and patient will have diarrhea. So this is completely absorbed. So what is the advantage? There is less chance of diarrhea. Now what we call this is decreased chances of super infections. Now this drug is incompletely absorbed. Incompletely absorbed. Now what is the problem? It will be killing our narrow flora also. Patient will have more risk of diarrhea. More risk of diarrhea. That is ampicillin. Another important is this drug undergoes enterohepatic recycling. Enterohepatic recycling. This will not, no enterohepatic recycling. Now where do you use this amoxicillin? We use it, usually we use amoxicillin with clavulanic acid. Now what is that? I will tell you, don't worry. And ampicillin is used with sulbactam. I'll tell you what is that later. Okay, the combination. They're called as beta-lactamase inhibitor. I'll tell you that later. Amoxicillin as such is used in the treatment of H. pylori. So when I come to H. pylori, I will ask you, where do you use amoxicillin? It is used in H. pylori eradication. Ampicillin is a very beautiful drug for managing H. influenza. It is a very beautiful drug for managing H. influenza and Shigella. So it is a very good drug for H. influenza and Shigella. And it is also a drug of choice. Ampicillin is a drug of choice for two important conditions. Very, very important. Number one, Enterococcus faecalis. Enterococcus faecalis, if you know Lee, there is one more Lee, listeriosis. So ampicillin is a drug of choice for two important conditions, faecalis and listeriosis. And it has very good coverage for the H. influenza, Shigella. So this is the difference between two drugs, amoxicillin and ampicillin. Usually ampicillin orally is not preferred nowadays because you know the problem. You have to give 4 times daily and diarrhea. But it's a very beautiful drug for H. influenza, Shigella, and drug of choice for Enterococcus faecalis and listeriosis. When you think of amoxicillin, it is one of the drug used in H. pylori eradication regimen. These are combined with beta-lactamase inhibitors. I will tell you what is that later. So they cover gram positive, gram negative, they cover Enterobacteriaceae, for example, the Shigella, they cover Salmonella, E. coli, Klebsiella, and all those things. So talking about aminopenicillins are contraindicated in a patient with Epstein-Barr virus infection. So Epstein-Barr virus infection, if you are using aminopenicillins, they are known to produce a rash, and the rash is not due to allergy, so it's a non-allergic rash. So patient may develop rashes in that patient, so don't use that in Epstein-Barr virus infection. Now I told you these drugs can cause diarrhea, but lesser chance with the amoxicillin, more chance with ampicillin. So the patient may have a risk of one more super infection, that is pseudomembranous colitis. Now, who will cause that? There is a pathological bacteria, that is Clostridium difficile, and that can also produce. And the risk is more with these drugs also. Aminopenicillins can also increase the risk of pseudomembranous colitis because you kill the normal flora, the pathological flora will increase and they can cause pseudomembranous colitis. Okay, so we solve the problem of short acting, then we solve the problem of the acid labile, then we solve the problem of narrow spectrum. But again, the problem is these are not going to cover another important gram negative, and that is Pseudomonas. So then we came with two more drugs. They are called as carboxypenicillins and uridopenicillins. So we have carboxypenicillin and uridopenicillin. So carbenicillin, we have carbenicillin and ticarcillin. These are carboxypenicillins. Uridopenicillins are meslocillin, then azlocillin and piperacillin. So the mnemonic is CT-MAP. So CT-MAP. Now these drugs are also called as anti-pseudomonal penicillins. These are also called as anti-pseudomonal penicillin. Sir, do they cover only pseudomonas? No, they will cover similar to aminopenicillin plus coverage of aminopenicillins. So whatever aminopenicillin cover, that also is covered. Along with that, whatever the aminopenicillins cover, along with that they also cover pseudomonas. That's why they have a separate heading, anti-pseudomonal penicillin. And the coverage is also whatever we discussed for aminopenicillin, that is amoxicillin and ampicillin. Okay, so carboxypenicillin and uridopenicillins. The next problem what we faced is the resistant issue. The fourth problem is resistance. Now the problem here is, suppose let us take an example here. This is your home. This is your home, or let us consider it's your room. Now in that you have kept a costly thing, expensive thing. Let us imagine a 10 kg of gold. So you have kept 10 kg of gold and you went outside. Now everybody knows that. Now how do you protect this? Pause the video and tell me. Number one, you will put a watchman there. Number two, you will give a big locker. You will put a very good locker. Number three, you will keep a watchman inside also who can throw it out. Third. Number four, you fool the people. Tell them you have kept 10 kg of gold here, don't keep it. Keep them some other place. So that is the fourth way. So same thing, the bacteria has the mechanisms to get resistance to the drugs. So they can ask you in the exam what are the mechanisms of resistance for bacteria so that they can survive. So number one, if we give the drug antimicrobial, what do? They can produce an inactivating enzyme. And what does it do? It will inactivate the drug. Number two, it can inhibit the entry. So it will not allow the drug to enter only. By chance, if the drug enters, the bacteria will get a pump called efflux pump, and that will throw the drug out. And number four, by altering the target, they can alter the target. So these are the four mechanisms of drug resistance. So these are the mechanisms of drug resistance. So this question had been appeared. They had given all the option and they had given DNA gyrase inhibition. DNA gyrase inhibition is a mechanism of action of the antimicrobial. These are the mechanism of drug resistance. See how the bacteria is trying to survive by producing inactivating enzyme. There is a watchman inhibiting the entry, that means putting a very big lock. Number 3, efflux pump. When the drug enters, throw it out. And number 4, fooling the drug by altering the target. So these are the mechanisms. Now once I know the mechanism, why are we studying this here? Why are we studying this here? Let me take an example. So we understood the mechanism of drug resistance until now. Let us understand why it is important in penicillin group of drugs. Now let me take an example here. This is a bacteria called E. coli. So E. coli is a bacteria which starts producing an enzyme called beta-lactamase. So it produces an enzyme called beta-lactamase. Now what is the role of beta-lactamase? The name itself is telling you. ASC means enzyme. So if this is the beta-lactam like this, now these will cut the beta-lactam here. This enzyme will cut the beta-lactam here. Now if you cut that there, the beta-lactams are not going to work. They are not going to work now. Now if they are not working, then beta-lactams are ineffective. So this is the beta-lactams are ineffective here. Then what to do now? If E. coli is producing beta-lactamase, then what to do now? What you can do is, you can inhibit this enzyme called beta-lactamase. So we have the drugs which can inhibit the enzyme. They are called beta-lactamase inhibitors. But if I use beta-lactamase alone, will they kill the bacteria? No. They are only preventing the enzyme from inactivation. This is blocked. But you have to send the drug also. So along with this, we have to use the beta-lactams. So if the beta-lactams are going to fight, they require a protection, and their protection is beta-lactamase inhibitors. Suppose you want to go to the COVID ward, you have to wear that, yes, you have to wear the protective gloves, protection. Then only you can enter, otherwise you will get infected. So otherwise beta-lactams get inactivated. So we use the combination. For example, let me take an example here. Beta-lactam drug is amoxicillin. It is combined with beta-lactamase inhibitor called clavulanic acid. Now what we did is, we synthesize a drug which is similarly looking like beta-lactam. So what they do, the enzymes will think that they are beta-lactams and they try to bind to the clavulanic acid, and the clavulanic acid binds the enzyme irreversibly. So once they bind it, they are gone. That is suicide inhibition. Again, the fresh enzyme has to come to the picture. So they can cause suicide inhibition of the enzyme. The enzymes will never work again. A fresh enzyme has to come to the picture. Similarly, we have ampicillin plus sulbactam. Then we have the piperacillin plus a beta-lactam called tazobactam. So these are all related to penicillin. But are there any other beta-lactams? Yes. Inhibitors? Yes, we have. So we have something called oborbactam. It is used along with ceftazidime, that is cephalosporin. Even this is being cut by the beta-lactamase, so protection is given by this. Then we have avibactam. Avibactam is given with another beta-lactam, that is meropenem. Then we have another thing called relebactam. So relebactam is used with a drug called imipenem. And imipenem is given with cilastatin. Why, I will tell you later. Imipenem is given with cilastatin. Yes. So these are the beta-lactamase inhibitors: clavulanic acid, sulbactam, tazobactam, oborbactam, avibactam, and relebactam. So all of them end with bactam. That means the scientists are brilliant. They made the chemical structure similar to bactam. So when the bacteria sees that, the enzymes will take thinking that they are beta-lactams, and when the enzymes bind, they are inhibited. And when the enzymes are inhibited, then the beta-lactam will go and kill the bacteria. Now, is there any other, do they kill the bacteria themselves? No. But sulbactam has shown to kill a bacteria called Acinetobacter. So it has shown to kill Acinetobacter baumannii. It kills Acinetobacter baumannii. That is the only one which has the activity to kill the bacteria. Otherwise, these don't have the property. Okay, so we overcome this problem. Beta lactamase inhibitors. So if an enzyme is produced by the bacteria, we can prevent that and use the drug. So that's why the combination is called beta lactam plus beta lactamase inhibitors. Now, let me tell you what do you mean by beta lactamase. Now, beta lactamase is a broad term. What does it involve? It is nothing but if it cuts the penicillin, they are called as penicillinase. If it cuts the cephalosporin, they are called cephalosporinase. If they cut carbapenem, they are called carbapenemase. And if they cut monobactam, they are monobactamase. So these are the different beta lactamases. So penicillinase, cephalosporinase, carbapenemase, monobactamase. So if they cut penicillin, they are called penicillinase, cephalosporin, cephalosporinase, carbapenemase, and monobactamase. Okay, sir. Then why are we studying this? Now, there are certain bacteria. I took the example of E. coli. Let me take that example again. This is the E. coli. Now, E. coli and Klebsiella. Now, when you think of E. coli and Klebsiella, what infection comes to your mind? You think of UTI. Now, when we are using antibiotics repeatedly, they acquire resistance. Now, what happened with E. coli and Klebsiella? They started producing ESBL. So, what does ESBL stands for? Extended spectrum beta lactamase. So, what do you mean by extended spectrum beta lactamase? Usually, beta lactamase means they should cut either penicillin or some cephalosporins. But what is this ESBL? This ESBL is going to cut penicillins, cephalosporins, as well as monobactams. And it is not going to cut what? If it is cutting these three, which is not being cut, carbapenem. So, if E. coli or Klebsiella is producing ESBL, what is the drug of choice? ESBL producing E. coli or Klebsiella. Very, very important question, repeatedly asked. The drug of choice is carbapenems. Carbapenems because they are not cut by the ESBL, extended spectrum beta lactamase. Now, sir, these are nothing but beta lactamase only, right? Yes. Can we inhibit them by using beta lactamase inhibitor? Yes. If carbapenem is not in the option, you can use one more thing. You can give a combination of beta lactam plus beta lactamase inhibitor. You can use this combination because when I use beta lactam, for example, if I am using piperacillin for this patient, if I use piperacillin for a patient with ESBL producing E. coli, piperacillin will be cut. So what should I do? I have to combine with tazobactam. Right? If I am using cephalosporins also, can I use cephalosporins alone? No. I have to use cephalosporin with beta lactamase inhibitors. So this is what is the meaning of beta lactam plus beta lactamase inhibitors are also used to treat ESBL infection, ESBL producing E. coli or Klebsiella infection. Very, very important. Very, very important. Okay. So recently they had given this option. They had not given carbapenems, or you search in the option beta lactam plus beta lactamase inhibitor. And the best one is piperacillin because it can cover the E. coli as well as Klebsiella. So this can be the question for it. Okay, so whatever we discussed till now is by producing inactivating enzyme, that is beta lactamase. One more important understanding what we need to understand in resistance problem is a story of Staph aureus. Staphylococcus aureus, I told you it is going to cause the skin and skin structure infection. Usually diabetic patients are going to be suffering with that, the abscess, the furuncle, carbuncle, and also it is known to produce pneumonia, hospital acquired pneumonias, and all those things. Now, the Staph aureus are brilliant. They have to survive. If they have to survive, then they started producing the beta lactamase called penicillinase. So they started producing the enzyme penicillinase. So this penicillinase will cut penicillins. So that will cut penicillins. Now what the scientists did, what should we do? Either I should inhibit the penicillinase or I should produce a penicillin which can withstand this penicillinase. So you think and tell me. Either I should inhibit the enzyme or I should produce a penicillin which is not cut by penicillinase. So the one which are not cut by penicillinase, these are called as penicillinase resistant penicillins. So penicillinase resistant penicillins are the penicillins which are not cut by penicillinase. So this is one solution what we got. So for Staph aureus, we have a solution. We synthesize a penicillin which are resistant to that. And what are those, sir? What are those? You already know them. You know oxacillin. For that you add Cl, you get cloxacillin. You add dye, then dicloxacillin. Along with that, we have other drugs called nafcillin, and one more drug is called methicillin. We have nafcillin and methicillin. Now, which are oral? Can you tell me? Obviously, these drugs, what you have written, so these are oral drugs, and others are injections. Now, the problem is oxacillin is it is a hepatotoxic drug. The drug is hepatotoxic, that is oxacillin. Nafcillin, methicillin are injection. Nafcillin, remember N for it can produce neutropenia as adverse effect. Neutropenia and nephritis. So N for two problem, nephritis, and the nephritis is called as interstitial nephritis. Interstitial nephritis. Same thing is a problem with methicillin. Methicillin also can produce interstitial nephritis. So we don't want to use these drugs. One is injection, second one is the adverse effect. So whatever we use is either oxacillin, cloxacillin or dicloxacillin. So what is commonly available in India is dicloxacillin. Now there was a question in the recent exam. A lady came with breast abscess and what's the drug you use? So one of the option was dicloxacillin. Now why dicloxacillin? Because a breast abscess, the main treatment is incision drainage. And why antibiotic? And why we should give dicloxacillin? Because most commonly it is caused by Staph aureus, and the best drug for Staph aureus is dicloxacillin, and it is having penicillin resistant action. So these penicillin resistant penicillin are also called as anti-staphylococcal penicillins. Anti-staphylococcal penicillins. Yes, because they are active against staphylococcus, they are resistant. Sir, we have not used dicloxacillin so much. We have done internship and we have not used it. Then what to do? Now the problem here is what we did is we made a penicillin which is resistant to penicillinase. Now what is the another approach? You can inhibit the enzyme penicillinase. So what is the second approach? The second approach is inhibit the enzyme penicillinase. How do you do that? By using beta lactamase inhibitors. So beta lactamase inhibitor plus beta lactams, you can use them. For example, clavulanic acid plus amoxicillin. Now that's the reason most of you would have prescribed amoxicillin clavulanic acid for this lady with breast abscess, but that was not even the option. So the next thing you can choose is dicloxacillin. You may ask a question, sir, can I give amoxicillin for Staph aureus alone? Can I give amoxicillin? If you give amoxicillin alone, it will be cut. So if you want to give amoxicillin, you have to add clavulanic acid, and it is not being cut. So either you give anti-staphylococcal penicillins, or you can give beta-lactam plus beta-lactamase inhibitor when you manage the Staph aureus. So this Staph aureus is also called as methicillin sensitive Staph aureus. So it is a name. MSSA stands for methicillin sensitive Staph aureus. Now we overcome that problem, we have drugs, but the bacteria is not going to keep quiet. It is also intelligent. Now it became resistant to methicillin, so we have the next one called MRSA. So MRSA stands for methicillin resistant Staph aureus. So methicillin resistant Staph aureus, so it will be not working for anything that is methicillin, ampicillin, oxacillin, cloxacillin, whatever. Now what is the reason for this? Now I told you there are mechanisms of resistance. One is alteration of target. Now beta-lactams, they have to come and bind to a protein called penicillin binding protein. So when they bind there, then only they will inhibit enzyme transcriptase. Now what happened with the MRSA? They altered this protein. So what they did is they altered the penicillin binding protein. So what happened if it is altered? Beta-lactams will not work. Why they will not work? Because the target is altered. So beta-lactams cannot bind now. If they don't bind, they cannot kill. So that's why beta-lactams are ineffective in MRSA. Beta-lactams are ineffective in MRSA. So whatever beta-lactams, penicillin, cephalosporins, then monobactam, carbapenem, they don't work at all. The reason is altered target, that is penicillin binding protein, except nowadays we have 5th generation cephalosporins which can work on this. Only they have activity on the MRSA. They have the activity on them. So the reason for alteration is because of the chromosomal gene, and that is called MECA gene. So that is responsible for the alteration of penicillin binding protein. Now, for MRSA, we cannot use beta-lactam except 5th generation. 5th generation, we are not using for simple infection. We reserve them for some serious infection, and they are costly also. So how to manage then? How to manage this Staph aureus, MRSA? Now, when you think of MRSA, there are two important problems. MRSA carriers. We have MRSA carriers. Sir, who are carriers of MRSA? Who are carriers? The healthcare workers, doctor, nurse, ward boy. Now they are carried in the nose. Suppose somebody touches the nose and touch the patient, they are going to infect the patient. So the first thing is, in the hospital, the MRSA carriers should be called and they should be treated, and the carrier state should be eradicated. So carrier state should be eradicated. So what is the treatment for that? The treatment is an ointment called mupirocin ointment. So this has to be applied locally into the nose. So we call them as nasal carriers. So for them, the ointment has to be applied for 5 to 7 days. If that is not there in the option, we can use bacitracin. So if both are given the option, what we will choose? Mupirocin is the first choice. In one of the exams, they didn't give mupirocin, they had given bacitracin. So again, these two have been asked. So how do you remove the nasal carriers? How do you eradicate that? Very good. Now, since beta-lactams are not used, what is the drug of choice for this? The drug of choice for this is vancomycin. So MRSA, the drug of choice is vancomycin. Now Staph is still intelligent. It became VRSA, vancomycin resistant Staph aureus. For this, the drug of choice is daptomycin. But daptomycin you cannot give in lung infection like pneumonia because lung has surfactant and the surfactant can inactivate the drug. So if it is VRSA pneumonia, VRSA pneumonia, the drug of choice will be linezolid. And one more important thing I just want to tell you, very, very important point, vanco, dapto, linezolid. These three drugs, they work on gram positive only. Please keep that in your mind. Vanco, dapto, linezolid, these work on gram positive only. And what is Staph aureus? It's a gram positive organism. So they work on gram positive only. So that is the story of the Staph aureus. So you can go with the story like this. Very, very beautiful story of Staph aureus. So we had methyl sensitive Staph aureus. Either you give anti-staphylococcal penicillin or you give beta-lactam plus beta-lactam inhibitor. Then we had MRSA because of altered penicillin binding protein. So beta-lactams will not work except fifth generation. Drug of choice is the drug of choice for MRSA is vancomycin. VRSA is daptomycin. VRSA pneumonia is linezolid. There is MRSA carriers in the nose. We use the local ointment, mupirocin or bezitracin. So that is how the resistance is overcome. See? So once we have overcome the problems associated with the first penicillin, that is penicillin G. So it was shorter acting, we made it longer acting. It was acid labile, we came with acid stable, that is oral penicillin. The third thing was it was having narrow spectrum. We came with extended spectrum penicillin, which can cover the E. coli, Shigella, then even Pseudomonas. We have anti-Pseudomonas penicillin. Then we overcome the resistance problem by using beta-lactamase inhibitor and the resistant penicillins, all those things. So we discussed the ESBL producing bacteria. Then we discussed Staph aureus in detail. Because why this was discussed in detail? Because they are very common infection and exam these questions repeat. That's the point. Now once we know this, what are the uses of penicillins? Penicillins are used in leptospirosis and listeriosis. They are used for actinomyces, then syphilis, then tetanus, then meningococcal meningitis, anthrax. So we don't have anthrax currently, so not to worry. Anthrax, then gangrene. Then another important aspect is yaws, and then there is something called rat bite fever. So these are the uses of penicillin group of drugs, and also penicillin group of drugs are also used in a condition called Enterococcus faecalis. I told you the drug of choice is ampicillin for that. So you can remember with the mnemonic last Maggie, M-A-G-Y Maggie, remains. So leptospirosis, listeriosis, actinomyces, syphilis, tetanus, meningococcal meningitis, anthrax, gas gangrene, yaws, and rat bite fever. It is also used in management of streptococcal pyogenes. It is also used. So that is the use of penicillins. So once we know the use of penicillin, are there any adverse effect? Yes. They are known to produce mainly hypersensitivity reaction, allergy. In hypersensitivity, the major problem is the type 1 hypersensitivity, that is, patient may develop anaphylaxis. The question here is, will all the patients have this problem? No. There are certain people who are allergic to the fungus. Now, why the allergy occurs? Because we are injecting material from fungus. So some are allergic to fungus. When we inject them, they will mount an immune response. That too, type 1 hypersensitivity reaction. Patient may go for anaphylaxis. So how to avoid To avoid this, we have to do a skin test. So that is called the test dose, and we give the penicillin at low dose intradermal. So we give it intradermal, and if there is some rashes or itching, we don't give it. So that is the main problem. But even though we have done test doses, patient has no problem. Even during infusion, the allergies have occurred. So you should be very careful when you are giving penicillin. The second problem is the cross allergy. Now, what do you mean by cross allergy? The meaning is simple. If the patient is allergic to penicillin, there is a high chance he is also allergic to cephalosporin and carbapenems. There is a chance, but every time it is not true. There is a chance, so you should not take a risk. So you should keep that in your mind before you give the cephalosporin and you are giving carbapenems. So there is no cross allergy with what? All others have cross allergy, but they don't have cross allergy with monobactam, that is aztreonam. So no cross allergy. So let me write cross allergy with cephalosporins and carbapenems. No cross allergy with monobactam drug. And the monobactam drug, let me introduce now only, it is called aztreonam. And the specific adverse effect I have mentioned there itself. Another third problem that happens is a condition called Zarich-Herxheimer reaction. So Zarich-Herxheimer reaction, it's a reaction, it's an inflammatory response. It's not an allergy, remember, it's not a hypersensitivity, it's a inflammatory response. So it's an inflammatory response to what? To dead Treponema pallidum. So when we use penicillin, what happens? It will kill the Treponema pallidum. The bacterial particles, they are released and the inflammatory process is on them. So that is called Zarich-Herxheimer reaction. This is seen only when you are using penicillin to treat syphilis, not in other condition. When you use penicillin to treat syphilis, then only you see this reaction. So it's not a anaphylaxis. So how do you treat that? This reaction is treated with NSAID, and that NSAID is aspirin. Why aspirin? Because it has anti-inflammatory property and patient can be sedation. So these are the three important problems what we see with penicillins. Hypersensitivity reaction, particularly dangerous one is type 1. Cross allergy with other beta-lactams, no cross allergy with monobactam. And only in syphilitic patients who are given penicillin, there is an inflammatory response called Zarich-Herxheimer reaction. So that is about penicillin group of drugs. Okay, so summarizing the things, we started the video with understanding the introduction of antimicrobials. I told you static, stop the multiplicacidal, kill. Antibiotic, they are obtained from some other organism, kill other organism. And then we discussed the target, cell wall, cell membrane, then the DNA, then the protein synthesis and metabolic pathway. Beta-lactams are 4: penicillin, cephalosporin, carbapenems and monobactam. Penicillin was the first antibiotic discovered. The problem is narrow spectrum, acid labile, and it was shorter acting. So we came with longer acting penicillin like procaine penicillin, benzathine penicillin. Then we came with oral penicillin, OC vada. Then we came with extended spectrum penicillin, amino penicillin, ampicillin, amoxicillin. Ampicillin is a drug of choice for fecalis as well as listeriosis. Then we came with anti-pseudomonal penicillin, CTMAP, carbamazepine, ticarcillin, meslocillin, azlocillin, piperacillin. Then we have another important thing, that is the resistant problem. So we have beta-lactamase inhibitors, they end with bactams, sulbactam, tazobactam, relabactam, weberbactam, avibactam, and clavulanic acid. So for ESBL producing E. coli Klebsiella, we use beta-lactam plus beta-lactamase inhibitor, or you can use carbapenems. Then anti-staphylococcal penicillins, they are oxacillin, cloxacillin, dicloxacillin, then nafcillin, methicillin. So they become resistant MRSA. Carriers, we use mupirocin or besidrocin. Mupirocin is best one. The drug options for MRSA is vancomycin, VRSA is daptomycin, VRS, and pneumonia is linezolid. And the main problem with penicillins are allergy, type 1 hypersensitivity. There is cross allergy, but no cross allergy with monobactams. And there is a reaction called Jaris-Arzim reaction. It's an inflammatory response. Give aspirin and sedate the patient. So that is about the first antimicrobial penicillins. Thank you all.